Thank you so much. If I could invite our first three speakers up onto the stage, please, for the Q&A. And I hope we have I know we've got one of our virtual speakers. If we could bring them up on the screen, please. Hi, Dr. Erickson.
Good morning.
Good morning.
Can you see me and hear me?
We can. Can we hear him, Arizona? There we go. We can. We're just waiting for Dr. Agnew, but we will go forward with our questions. Okay, well, thank you. That was two great sessions. So we're going to start with Dr. Custer, a question for you. What is your opinion of piercing the vagus nerve in the ear? Is it beneficial to calm down the nervous system? What's your opinion of piercing the vagus nerve in the ear? Yes. Is it beneficial to calm down the nervous system? Based on your reaction, I'm going to go with no.
Listen, I learned a long time ago not to prejudge things. That I think we can have quite sort of black and white views about things. Listen, the nerve supply there. When you have acupuncture points that are particularly sensitive, you can needle them, you can stimulate them, tap them, you can press them, you can hold them. Why would having a piercing and moving it not be a similar thing? So I imagine it. I don't think there's any evidence to support it, but yes, learning about the vagus nerve innervation and how to stimulate the vagus nerve was really a breakthrough for me, because it's just one example of somewhere that you can easily manipulate. And as long as you pay attention while you're doing the stimulation and do it very gently, you'll notice changes in your body. You'll notice increased salivation. You'll notice a sensation in your abdomen region. It's like anything, the sensitivity is really important. So you have to stop and ground yourself and give aside a minute or two to really listen to what's going on in your body while you do it. Whether that's the twiddling an earring, I don't know.
Thank you. Dr. Atwell, is there a genetic test that someone could do on their own without a doctor's order?
That's the many genetic tests. There's obviously recreational type genetic test. I don't think the question is alluding to, but without a doctor's order, I think that's you can go to some companies now and go online and have it basically buy a test and ask to see. There's usually a genetic counselor or some professional in the background that's approving it. So it's technically still with a doctor, but it is possible to do it that way.
And I guess the main question is would you rely on consumer genetic testing?
It depends on the lab and all, and what they're doing exactly. But in general, I would proceed with great caution. One of the things with genetic testing is the interpretation of the test. The sequencing is often the easy part. It's understanding what it means, and did you order the right test out of many thousands available? Did you explain what the results mean and what they don't mean, and the limitations of those results? There's a lot of nuances in that most doctors outside of genetics just will struggle with. So I would proceed with caution. I see a lot of people doing these online genome sequencing tests, these different companies. I find the clinical utility to be limited.
Thank you. Dr. Shepherd, how do you create a meaningful life when what you loved to do was taken away from you?
That's interesting. That's a really good question, actually. And I think one of the first steps is to acknowledge a sense of loss and think about having to adjust and adapt to the reality of the situation. Because if there's a failure to adjust and adapt, then what's being maintained is suffering and distress. And I'll give you an example of like this in operation. So I had a client, and she had EDS, and she was being supported very much by her her parents. And then her father had a stroke, and it kind of like wiped out his left side. And he was quite young. He was fit as a fiddle. He didn't drink. He didn't smoke. But suddenly his whole world had changed. And she could see that he was struggling. And she came to me, and we thought about a plan about how to help this person. And I said, why don't you ask him about what matters to him in life? And I think he used to be a carpenter. So she came back and said, well, I used to be a carpenter. And I said, well, what was it he loved about kind of like being a carpenter? I said, well, he loved helping people, and he loved using his hands to fix things. But now, of course, that's been taken away from him. He can't do that. He doesn't have the manual dexterity to be able to do that. And in that situation, it's very easy to see kind of like, well, okay, he's had this adversity. He's always been a carpenter. He's always loved it. But actually, how can he make a meaningful life out of this? And so what we did, we took a step back, and we just thought, in an ideal world, this man would be able to continue being a carpenter. We don't live in an ideal world. So what's the next best thing? And what we know is what mattered to him was helping people and creating things. So within his limited world of, he was in a rehabilitation center, what could he do that could connect with those values? And the thing that he came up with at that time was, the physios asked me to try and get around as much as possible, so I could get myself around the ward and talk to lots of people and try and encourage them to continue their physio. And perhaps I could also just write a blog about my experiences of rehabilitation. Now that's a far way from being a carpenter. However, it's still connected with his values, which were helping people.
Yeah, thank you. That's very helpful. We did have Dr. Agnew there. Did I imagine that? He seems to have gone. Oh, there he is. Hi, Dr. Agnew. How are you doing?
Well, thanks. I was just looking for headphones. I hope you can hear me.
Well, I actually had a question for both you and Dr. Erickson. And I'll start with the answer from Dr. Erickson, please, and then come to you, Dr. Agnew. Many people who have EDS seem to have short-term relief from various surgeries, but the positive effects don't last long. Have you had experience with long-term success with your surgeries? So Dr. Erickson first.
Yes, the universal problem for EDS patients is the median nerve entrapment at the elbow, which causes painless weakness of these two muscles. And fixing that gives you immediate and permanent return of that strength. I've not really had a recurrence since 1996. And when that person who was not an EDS patient, just hypermobile, when he recurred, it was because of a second layer of muscles further out. And since 1996, we look for that layer at the same time of surgery and release it if we're there. The second thing is that by the time patients see me, they've usually had several years of symptoms, and it's caused postural issues that cause the head to come forward and the shoulder to drop, and then the brachial plexus gets a tug, and the whole arm aches. And it causes vague, intermittent arm and hand pain from a more proximal source. And if you look at the patients I wrote up in a presentation I had in New York City in 2004, which you can download from my website, there's 100 patients in a row operated on for the median nerve at the elbow. And the success rate in terms of relief of symptoms was around 80% had complete relief, and it was needed nerve plus whatever else was sore. And about 80% had complete relief of their symptoms, another 16% or so were much better, had mild residual symptoms, and 5% or so had no change in their functional status, meaning if they weren't working, they didn't go back to work. And those patients all had thoracic outlet issues. There were some other things like depression and neck arthritis, and they were like, if they have 4 out of 6 things, my surgery didn't change their position in life. So since about 2004, we've tried to look at patients from 20,000 feet and address the thoracic outlet issue preoperatively. And if patients have residual functional limitations after surgery, it's almost always related to their thoracic outlet. And I have up to 17-year follow-up for people with a wrist instability issue. And the thumb operation, I haven't had to revise anyone in the last 17 years if the cartilage was normal at the time of surgery. So these are operations that work even in EDS patients with persistent relief, and the failure of surgery in my patient population is not really the failure of surgery, but the background of thoracic outlet issues. You know, the thoracic outlet is much smaller and tighter in women and men. I think these conditions hurt more in women and women's bodies are much more complicated than men's. The neck joints are loose, but the muscles are tight. So the neck becomes straight and stiff and less resilient. Breast weight pulls women forward. It doesn't help to be seeing doctors who trivialize their complaints. And another problem is that the symptoms are intermittent. So someone's wrist might hurt so much they cry at night after a bad day, but when they see the doctor, they're fine. And the doctor just thinks they're nuts. And if they are nuts, it's because the doctors make them nuts. So I would say we were, yeah. If you have a strong-willed, pain-tolerant person who only goes to see a doctor when they can't adapt anymore to their circumstances and they get invalidated, and the implication is that there's something wrong with them rather than their arm, you can take someone that's on the edge and push them over pretty easily. And I see this routinely. I'm sorry about that.
Thank you. Thank you. Dr. Atwell, what do you think? Sorry, not Dr. Atwell, Dr. Agnew.
So I was cheering along with the entire crowd there. Love just brought me some headphones. I hope you can hear well. Yeah, I could have said that better myself. Even if my voice was 100%, which it is not today, I hope that's better sound. Certainly we experience those same challenges, but also don't have as long a follow-up on foot and ankle reconstruction. What I would say though is that the materials chosen for the procedures we're doing, I think, are critical. Often bunion operations, ankle stabilization operations, and other rely on ligaments that have already failed once to be replaced by other native materials like tendons or adjacent ligaments. And of course, they're going to gradually fail too through a process called creeping substitution, where native collagen eventually replaces whatever material's been put in there. So we've designed our procedures to go through minimally invasive incisions and use durable materials like non-absorbable suture, metals, and sometimes combinations thereof, or more often than not, combinations thereof. So these things, hopefully, when someone digs up the community of Virginia Beach in 1,000 years, they'll find all these perfectly straight toes and tight, stable ankles by archaeologists.
Thank you. Okay, Dr. Custo, back in the room. What do you think about depression? Is it okay to just accept it, even though there is a lot of stigma about it? Or is it important to treat it instead of just living with it and accepting it?
Good question. I think defining depression is really important, first of all. So there's a difference between mood instability and emotional dysregulation, and difference between that and depression. There's a difference between dysthymia, which is more of a background, long-term temperament-like mental state, difference between dysthymia and depression. There's a difference between the type of depression you get in a regular depressive disorder from a bipolar disorder depression, and how you approach all of those things. And finally, there's an important understanding that depression is often underpinned by unresolved traumatic material, that something's got stuck along the way. A big T trauma, like a big car accident or something devastating, a small T trauma that might have been a comment in a playground, a single event trauma, or a more chronic, complex trauma picture. All of these things influence what might be driving this depression, as does what I mentioned before, the idea that there may be other physiological explanations that are causing the depression. So that's the first thing to say. I don't think you can answer the question in a very simple way. I think if there's trauma that's underpinning, it's important to treat the trauma effectively. And there are very effective approaches now for treating trauma. Depends where you are and what's available, but something that involves the body particularly, I think, is important. So eye movement, desensitization and reprocessing is good. The tapping approach, EFT, is excellent for digesting material. Then if you've cleared trauma and you've addressed any physiological issues that might be driving it, then you have to think, if you're dealing with a true depressive ill episode, you have to think that that is like a toxic effect on the brain. And the longer you remain in a properly deeply depressed state, the more damage it will do to the brain. So in that situation where you've reversed things that are reversible and you've addressed things from a psychological perspective, and you know that you're dealing with someone who is properly clinically depressed, and some of the features of depression are persistent, low mood most of the time, a lack of enjoyment or pleasure, and reduced energy, which is a difficult one in the patient group for obvious reasons. But if you have that clear and diurnal variation, so usually the mood is worse in the morning and better in the evening. And if you have a good going depression, absolutely treat it. Treat it with antidepressant medication. And if you're going to treat something with medication, treat it properly. That doesn't mean dive in and go in fast and hard. It means go in low and slow, but don't compromise along the way. I always say, if you're going to treat depression and you see a clear but partial response, so someone comes back to you 2 weeks later and says, yes, doctor, I'm feeling definitely different, but I'm still quite stuck and low and so on. And first of all, I'd wait more than 2 weeks. I'd wait at least 3 weeks at any one dose, but I would increase the dose until you find that sweet spot where someone is optimally treated with minimal side effects. And if you can't find that with one medication, you move to another. And everybody has different genetics. And we know, I often do pharmacogenetic testing with complex patients on multiple medications. And we see that there are genetic variants that make you more likely to have side effects with this group and more likely to have toxicity with this group. So you can get some guidance from that. But I think doing one thing at a time, having a clear sort of rationale and approach, starting low and going slow, and not being afraid to increase the dose until you've got the results you want, would be some of the tips that I'd give.
Thank you. Dr. Atwell, what are the recommendations for people who receive variants of unknown significance that are associated with the rarer types of EDS?
That's a hard question. So first, I think we should just clarify what is a variant of uncertain significance and why does the lab call it that? So we're all unique in the sense we have unique variants that no one else has. Hence, that's what makes us individuals. So when the lab sees one of these variants that it's never seen before, or it's seen very uncommonly, maybe once before or a handful of times, it's very hard for them to know what the clinical implication, if any, is for that variant. And sometimes it's easy. It doesn't cause a downstream change in the protein and other things, but sometimes it's actually quite challenging. So they call it a variant of uncertain significance. And there are lab geneticists that are very competent in sequencing and interpretation of lab data. They're not clinicians. And so what I find that the most useful thing is to have the lab data there and then overlay that with the clinical data, or in this case, phenotype or the symptoms that the patient has. So if there is limited, if any, correlation, it's fairly obvious it's not causing anything. If there are, and we also know that over 90% of variants of uncertain significance, just by having them for years and years at this point, most of them are reclassified as benign variants down the line. So the other thing is looking at what the condition causes and what inheritance pattern it is. So for example, if it's one variant of uncertain significance in a recessive gene, and that's the only thing reported, it's not going to be causing anything. So it's a little bit nuanced, but you have to look at it from multiple angles. I try and give patients some strong guidance on variants, and not to. Often they're just getting. It's easy to say, oh, well, we're not sure what it means, and come back in a year or something like that. I don't find that is the best approach, because then we'll start worrying that variant's something significant. There's always something there that overlaps, like joint pain. Well, yeah, a million things cause joint pain. So it's looking at the lab data and the clinical data together is, I think, the main thing.
Thank you. Dr. Shepherd, what's your opinion on how these approaches to psychology could risk the idea that we are responsible for our physical problems? Tools to help us in times where we've been hit time and time again, and understanding that our experience is valid and important. Would perhaps trauma approaches be appropriate as part of the psychological support for those living with chronic illness?
Yeah, I've done some previous talks about trauma, which can be accessed through the Ehlers-Danlos Society website and on YouTube, because I thought trauma, as James mentioned, is a really, really important thing. But with psychology approaches, it's not a one-size-fits-all approach. So one of the first things that we do during assessment and in the first session is develop a formulation for that particular person, an individualized formulation to really understand what the stresses are or were that contributed to this person being in the room with you now. And then quite often what we're trying to do is motivate somebody into not necessarily thinking about kind of like what necessarily caused the illness, because it's difficult. There could be a mixture of genetic things, biological things, environmental pressures. There are some things that we might have contributed to things not being the way that we'd like them, that we did ourselves. But quite often the blame game is not necessarily useful. And what we want to do is just think about, in the context of everything that's happened, what can we do here in the clinic session that's going to help you move towards having that rich and valued life? What's going to give you some purpose? What's going to give you some independence again? Now, some of that will involve doing some trauma work, and everybody's experienced traumas, but sometimes these traumas are unresolved. And so you could have unresolved traumas. You could have, as James was talking about, big T traumas, little T traumas. You could have PTSD, where you're having lots of re-experiencing symptoms in the present, such as nightmares and flashbacks, etc. And really, it's just having a chat with that particular client to think about whether it would be useful to do some trauma therapy then and there, or perhaps if there's an idea that that's not necessarily affecting so much of their life now, moving towards just thinking about, okay, so how can you manage things better in the present moment that will give you a better quality of life? So, you know, sometimes I'll have a client in front of me and I'm thinking there's lots of unresolved trauma here. And I suspect that, in a sense, some of the unresolved trauma is getting in the way of your body healing as much as it can. However, that person might not be ready to address the trauma. And if you address the trauma when a client is not ready, you could make things worse. So I'm always having a discussion with the client to think about whether it's the best time to do the trauma. Because when you do a trauma therapy, it tends to evoke some distress. And you need to be in a kind of like a strong enough position to be able to tolerate that. Now, sometimes we might think, well, you know, let's just kind of like pause on the trauma therapy at the start. And let's just think about what needs to happen for things to be a bit better for you. Now, that can be a really practical approach, such as trying to improve sleep, trying to have techniques, cognitive techniques to manage worry, trying to improve relationships in the present moment. And so it's really just having a conversation with the client to work out what the focus should be initially in order to give that person a better quality of life. And then after that, reevaluating and then deciding what the next focus should be.
Thank you. Dr. Erickson, is there anything that can be done to improve scar tissue healing post-surgery for patients with EDS?
Yes, we have a number of things that we do for these patients. First of all, we try to go to the operating room once and fix everything. So there's less risk of anesthesia, there's been one recovery period. The second thing is we are extremely gentle with the tissues. We pretend the patient's awake, so there's less trauma. We don't use epinephrine, which is sort of in vogue these days for using local anesthesia instead of general anesthesia. But if you have a person with delicate tissues and you cause 6 hours of no blood flow, skin can slough. So we tend not to use epinephrine unless we're using a bigger incision and really gentle techniques. We also use tranexamic acid, which makes the fibrin stable, so there's less bleeding. We also try and not cut any blood vessels at all, so there's less bleeding. Blood is sort of an initiating event for scar tissue formation. So typical blood loss on my patients for these surgeries, even if there's 15 procedures between tendon, nerve, and joint problems, blood loss is typically less than 1 cc. We close the incisions with internal stitches. So there's less trauma, less scarring, less pain. The pain ends pretty much, at the time of surgery. We also give ketamine intraoperatively, which tends to interrupt chronic pain cycles. So a little ketamine and Versed can make the whole surgical procedure easier to bear for the patient, and then they're not in as much pain afterwards, so they're more likely to move things. And moving things early causes less scar tissue formation. So you get things to glide. We also give people celestone or betamethasone injections at the time of surgery adjacent to the surgery, which goes a long way to reducing the swelling and stiffness that occur after surgery. So people can move things earlier, and moving things tends to make things not stick. Another thing we do is try and establish reasonable expectations. Like, you won't find hundreds of testimonials on my website saying that I walk on water. I don't. We try and establish reasonable expectations and then exceed them, like under promise and over deliver. So when you under promise and over deliver, people are generally much happier. So those are the approaches I would advocate for reducing scar formation, trying to make the whole procedure less painful and moving things early as a result of less bleeding, less trauma.
Thank you. And I'm so sorry, Dr. Agnew, we had lots more questions to ask you as well, but we have run out of time. So thank you to all of our speakers from these two sessions. Thank you. Okay, it's break time now. How's the temperature in the room? Better, good. So I just want to remind people if they need a quiet room, we do have one round to the left if you wanted to just chill out. Please, please, please help us and buy all of our merchandise. We cannot take it home with us. And we've got some special edition Arizona stuff there. So please, please visit the stand and clear us out. And also you'll notice we have the most amazing graphics team. We have a media room just round to the left by our shop where one of our graphic designers is in there ready to take your pictures so that you can be on all of our promotional materials in the future. If that's something that interests you and you'd like to be involved, help us raise awareness and show what it's like to live with these conditions, they'll be in the media room on the break times and during the conference. So please head there now and register your interest. Have a good break, everyone. Thank you.